Good evening, everyone. Um, Welcome to Doctor's Assistant channel, discovering medicine again together with you. I know it has been a little bit of a quite a break. Maybe we met a week before live, uh, just juggling little bit between the work timings and the passion timings. So well, once again, thank you for choosing your time to watch this video or watch this session. Okay, so if you have watched already the trailer, the black box case or the black box trailer, this session is going to be um, um, an idea, okay, an approach to any patient who presents to you, okay, and that's how it is going to expand. So what the scenario here is that there is a patient who came to us, and the approach that we had towards him to diagnose him or to find what was happening with him, I'm going to discuss that in this black box presentation. Okay, and the approach will give you an idea about how to go about a case if you're a student or a practicing physician. Also, you will be in the word of wonder when you're discovering, oh, is this all possible? uh, the presentation will be a real eye opener for you, and it's also, I want to warn you that this is a highly condensed topic. So you need to be really intentional when you're watching this session, and focused. Okay, so without wasting much time, we'll begin the presentation now. I'm going to start sharing the screen now. Okay, so well, when you're presenting the quite the way, like it just shows like how I'm balancing both my passion and the work. And you have in this period where human interaction is very less, given me a purpose and way to interact with people. Thank you for being with me on this journey. First thing is, let's see who came to us. The patient was a 23-year-old male, and he belonged to religion Hindu, which sometimes is necessary to know because of the customs and traditional differences that are there, so that we can see is there anything significant or important to find there. And was hailing from West Bengal. Education, he was a ninth standard, uh, and by occupation he was a cook. And informant was self, and the reliability of the patient was fair. Well, the reason why I have put fair, is not because of his education. It is not because he was a ninth standard, and that's why the history is not fair. It's not like that. Now imagine talking to this person in pain. If you are going to ask him, how did this all begin? Who came to you? How did you get injured? You think the response will not be that reliable, right? The patient who came to us also was like this. He was with severe pain, and any history we would ask him would turn out to be unreliable, right? Or at least difficult to interpret. Surprisingly, our patient actually um, his history was highly credible. And I will tell you why. There is a link how you can find whether the history is credible or not, whether the patient is giving you accurate details or not, right? So let's see what brought him to us. His chief complaints were fever for 1 month and pain in multiple joints for 1 month. So a little bit digging into the history of presenting illness. The fever was of sudden onset, moderate to high in grade, and he had 1 to 2 spikes of fever per day with occasional chills. And then there was pain. When we tried to elicit history from for the complaint of pain, um, what happened is patient woke up one day and he had fever. In the morning when he woke up, he had fever. Along with that, there was chest pain. So it started with fever. But it was not that it interfered with activity on the day one, but it worsened immediately the next day to interfere with his daily work. Okay, so this would qualify as an insidious onset. And then pain and the fever, they were gradually increasing with respect to the frequencies 1 to 2, but with respect to the interfere with his daily activities, that worsened. And by 15 days, he was bedridden, right? And two of the things which is important to know whenever there is joint involvement is the symmetry of the joint involvement and whether the large joints are involved or the small joints are involved. Based on this, we get to diagnose many conditions. So these are the two questions that add on whenever there is joint involvement. And this patient had an asymmetric, and there was no sparing of joints. We couldn't say like he was not complaining pain in fingers. He was complaining pain in every possible joint. Okay, but mostly when you try to elicit a little bit in detail, he would point towards the joint which were in more use, like the larger joints, which he was standing and things like that. So we could uh, say larger joint predilection was there more than the smaller joints. Okay, uh, well, no one likes to hear no from people, right? But one place where you can like to hear no is history of presenting illness. When the patients see, when the chief complaints is told to you and when you try to elicit history, your background thinking happens. You start diagnosing the conditions ultimately, which is the aim of you taking interviewing the patient. But when you have this background knowledge about some illnesses and you're trying to frame questions to find the diagnosis, many times it's the no which builds the credibility for the patient. Consider this patient says, are you having difficulty in sleeping? Yes. Are you having difficulty in eating? Yes. It's like it decreases the credibility of the patient. Someone who is very highly sensitive, who is concerned, he would say yes for everything. Are you worried about your future? Yes. Are you worried this will never go? Yes. So when there is a no, for example, in this patient, when I say it's highly joint involvement, which is like inflammatory in origin, and I ask for redness, I ask for swelling, I ask for tenderness in the joint, I ask for warmth, and if he says everything yes is less reliable, then he's saying no when it becomes more reliable, because it's like you are asking something and patient is having an opportunity to evaluate, and he says yes for something and no for something. That builds high credibility. So this is one place where you should enjoy listening to no. But I also want to give a caveat. It is only that if you, the more you hear no, patient is reliable, but that doesn't mean that you are reliable. You may be still be asking question which is very vague and non-specific. So this builds only the credibility of the patient, not the one who is interviewing. So just watch out. It's not like you're going to ask many questions which is a no and you're going to build a very good history. That doesn't happen. Okay. So just to complete this history of presenting illness part, besides whatever I told you already, everything else was negative. I have concised them here, but if you're looking, I would like to know if this patient had skin rash. Well, the answer is no. Or if you're asking like, did the patient have a burning micturition? Like, can it be urinary infection? The answer is no. Right? So I have concised this, but anything beyond this, any questions you have? Oh, sir, can this be this? Can it be this? Well, the answer is no again. Okay, so there is no obvious foci of infection. You didn't find any infection foci, no signs of inflammation. Though he complained all joints, like, and it was the pain was also very severe. You like if the patient says, "Oh," like that. Now, if you're trying to move his finger, you would say, "Ah," that much of pain he was. He was bedridden. You see the imagine the picture. That's how he was, but there was no signs of inflammation in any of the joints. Neither at neither in any time of this 1 month period, neither on presentation. But anyway, we are sticking currently at the history level, so there were no signs of inflammation. And then no other constitutional symptoms. Constitutional symptoms refer to the symptoms which can be in many conditions. Like for example, dyspnea is a condition that can be causing system involved would be cardiovascular or a respiratory. Weight loss could be a constitutional symptom for many. So those things were also not there. The skin rashes, weight loss, everything is included inside this. Okay, next we go to the past history. Well, with past history, humans have a very unique relationship with past, or should I say, more attachment with the past. They are constrained by what happens in the past, right? Currently, look, many people now actually are in the impact of COVID and lockdown and business issues, because they have an attachment with how it was before. Can I be going to malls like before? Can I be going to restaurant like before? Can I be meeting friends and partying like that before? But that's the kind of attachment that is there, right? That is what the relationship that humans are having with the past. And when they are so much attached, they're not present to the kind of quality that they can spend now with family members, the kind of advances that are being made in the technology. Like me meeting you, I enjoy this, right? So if you're constrained too much by the past, then you don't get to live what's happening now. So that's a strange relationship with the past, right? But one place where knowing the past really helps is in medicine. When you try to elicit the past history and you get all the details that are there, it really helps. So when we try to get this answers from past history, like can we make a diagnosis from past history, this is what we got to hear. He had been treated for similar complaints 5 years back. Okay, but the issue is it was not reliable. The reason being, the patient's age was 20 to 23, and if it was 5 to 6 years back, he would be 15 to 16-year old, and with no reliable attender with him. Remember, he was from Bengal, so he didn't have much relatives. He had a someone, a distant relative, who was accompanying to meet us, and also with no treatment or diagnosis related details available from documents. This was a questionable evidence to consider. But still, anyway, you can't ignore them, but you will consider. But also, you will need to understand what is the diagnosis that is being given to him. So this is what Okay, so there was a technical disruption with the internet. Looks like it's settled. Hopefully, it will remain settled. Thank you for staying. So, going back to the presentation, I'm going to start sharing the screen now again. Okay. So, patient was moderately built, and I said the picture was that he was on bed and flinching with pain, with minimal movements of the body. Okay, then we when you measure the vital parameters, he was stable. He was there was no life-threatening hemodynamic decompensation or too much to worry about as per his vital signs were considered, except for one remark I have about the temperature. At presentation, he was not having fever, but his history was reliable in the sense that during the course of his admission, the patient tend to have fever, one or two spikes, as he told, and it was documented more than 100 degree Fahrenheit in many occasions. Okay, so that part of the history, that fever was reliable. And then the other things that you need to look when you're in the general physics examination, these are what typically a student would present. There was no pallor, icterus, anosis, clubbing, lymph nodes, or edema. Well, the palpable lymph nodes or edema. But no, that is not the ideal way to present this part. You need to prioritize. For example, in this patient, I will be interested in knowing whether there were palpable lymph nodes or pallor. Okay. And then there was no icterus, cyanosis, clubbing, or edema. But I'm interested in this, so I'm prioritizing it that way. So when you're presenting, don't just present the mnemonic pickle or pallor or pencil. Okay. What you're going to do is you're going to choose what is important and you're going to prioritize them. Next, systemic examination. The four major systems were examined. So if you imagine the patient again, it is not possible to have a detailed examination. Well, for RS and per abdomen, that was sufficient. That kind of cooperation from patient was sufficient. But for nervous system, we couldn't have a complete detailed examination. But in the limited evaluation we had, he was normal. In the cardiovascular system evaluation, there was a short systolic murmur that was there in the mitral area. Okay, so we are not discussing too much about the murmurs today, but there is already one video about the murmurs we have made. So that is the link will be in the description box of this video. So if you're interested, you can check it out there. Next is the joint examination, the specific complaints they had. So you need to do some local examination. Well, all joints were examined, but typically when the large joints were involved, more focused attention was given to them also. And they were negative for signs of inflammation. So even there was no joint tenderness. So you are going to press the joint line and you elicit tenderness. Even that was not there, and no other signs of inflammation like redness, tumor, or the swelling, warmth. Well, with regard to the loss of function, that is the one of the cardinal sign of inflammation. Well, that limitation was there. So if you want to take like signs of inflammation that as a serious one, you can say like only that sign was positive for sign of inflammation. Well, but range of movements was not tested for the same reason. We couldn't test the range of movements because he would just he would express unbearable expression on his face. So we wouldn't risk testing range of movements in this patient. Well, now that then after the history and examination, you are left as a patient to make a diagnosis. The ultimate goal of whatever we did till now. So the condition was fever with arthralgia, a simple case. Okay, but so very complex interpretations. And I want to tell a student here. Okay, there are no cases which are complex. If you are someone who is going to the ward saying that, oh, this is a complex case, this is a difficult case, forget about it. The cases are never complicated. Patient just says what is there. It can't be complicated. What is complicated is the interpretations. So fever with arthralgia is not a difficult thing to understand what's the complaint or what is the history about. Now it is the interpretations that needs the proper design for you to handle what you call as complex interpretations, which we're going to work on today. Okay, so this is something which lets you elicit the causes for anything. Okay, which again there is another link which says what you can answer anything, how to answer anything, discover. That link also will be there in the session details, the description box after this session. So if you want to get more details, you can watch that video. Well, but basically we are building the foundation of how to generate the causes of fever with arthralgia. And currently I have chosen those things which will present as fever and polyarthralgia. Okay, so the highlighted ones are the most likely ones. That's the approach we will have. Viral arthritis, tuberculosis, Lyme, which is caused by Borrelia burgdorferi, reactive arthritis, which margins between infection and inflammatory conditions. I have placed it in between. There are a plethora of inflammatory conditions that can present with fever and polyarthralgia. So you see the big list there. If you are a student and you're watching this, I would recommend you taking screenshots as we go. Okay, so that will help you have a reference if you are encountering sometimes the cases. In the next coming slides, you will be a little bit more active in taking the screenshots. That's what I would recommend. There could be infiltrative conditions. It could be cellular infiltration, hematological malignancies, or acellular infiltration, like crystalline arthropathies, uric acid elevation, things like that, or a paraneoplastic arthritis, where malignancy is somewhere else, infiltrative condition somewhere else, but causing joint pain because of the body's response to that malignancy. In this case, we didn't have too much evidence to support inherited iatrogenic idiopathic was the last one, and the relevant system. There were joint involvements, the way by the range of movements, and fever was documented. So we were not looking for any relevant system in this, but there was a uh, surprise for us, which was waiting. We'll tell you. Um, this drug induced was ruled out because patient did not go without a complaint and something he took, and he had fever, and that's when he went. So that also was taken out. So with all these things, you can't have everything on your plate and then eat, right? So first thing is you have to start somewhere, because plate can have only one, few spots, few fillers, right? So you need to pick and choose when you're having this kind of patient. So we went to go ahead with two possible things. The thing that were highlighted in the top, right? Connective tissue disease or infection. Okay. On this background, the patient's favorite drug, many of the practicing patients, whenever you have a complicated case, loosely using ceftriaxone is the trend now, justified in many ways. I don't have a complaint with that. And analgesics, given the patient's complaint, we went ahead with this approach. Okay, and we had some preliminary investigations because before just getting what connective tissue is, and we will just use immunomodulators. We wanted to just try out these things for a few days, and then when you assess the patient's medical record, these were the preliminary investigations. Well, this reference ranges may vary from textbook, but this was the reference range of the laboratory where the samples were sent, right? So you don't have to really believe this is the standard. You can still choose what is standard in the standard books that you are going to read. But I want to highlight what this patient had. So henceforth, what is highlighted in the red are the things that were abnormal. So patient had leukocytosis, microcytic hypochromic anemia, erythrocyte sedimentation rate was 94, and CRP was elevated, which was 19. Okay, so this gives a picture of infection. See here, if the patient had CRP of normal, then it would indicate an inflammatory condition. When the CRP is elevated, mostly it points to an infection. Even if it is a connective tissue disease, CRP can be elevated, but in them it indicates there must be a secondary infection also. So CRP is a marker for actually infection, this C reactive protein. Okay, so the patient has microcytic hypochromic anemia, which can be a possible anemia of chronic disease. But anemia is not much, 12. Some labs can have 12 as the normal reference range. But still, according to this lab, he has microcytic hypochromic anemia, which is also the most common cause of type of anemia seen in autoimmune disorders. Okay, so this was the complete blood count. Well, moving to the next reports, patient's blood sugars, renal functioning, and electrolytes were normal. When you move to the liver function tests, including the albumin globulin ratio, sometimes there are cryoglobulinemia, some viral infections like hepatitis C, which can present with elevated protein that's causing the damage. So that's something like that was not found here. And including the coagulation profile indicated by PTINR, that was also normal. Okay, and then after in the preliminary, we also included some investigations which would tell us whether it was really some specific condition. Okay, the first thing was for rheumatoid arthritis, factor that was negative, and ANA that was only 1 plus, which was also commented as insignificant. Then there was anti-streptolysin O. This was elevated in red. right? And this indicates there was a recent streptococcal infection. Then blood culture sensitivity was positive, and it had E. coli, Escherichia coli, sensitive to ceftriaxone and aminoglycoside. So we added some antibiotics to cover this because patient was not responding at this time. Okay, and there were viral markers HIV, HBCG, HCV. As I said, these viral markers can be presenting with fever and polyarthralgias, all these three viruses, and they were found to be negative in this patient. Sometimes, see, we just took a chance. I was not suspecting chikungunya, but what if by chance the history is not reliable? We should not be missing that. So we included chikungunya, just uh, assuming that history is only of short duration. That proved to be negative. Autoimmune condition, when you're suspecting, you can look for thyroid profile. It was normal in this patient. There was no muscle involvement. This is by CPK total, which was within normal limits. And the chest radiograph was normal. Joint radiograph that the patient used to complain, those were normal. And 2D echo supported what we found clinically. There was moderate mitral regurgitation in the cardiac area, in the mitral area. Okay. So what happened with all these things, with preliminary investigations and treatment? We failed. We failed to make any difference to the patient. Patient continued having fever, continued complaining about joint pains, continued his condition of helplessness where we couldn't do much in the beginning. Okay, so then we resorted to seek support of something which everyone seeks support of, especially in conditions like this, including current condition. If you look at COVID, even that also is now currently this is what forms the basic treatment protocol included in all most basic treatment protocol for even current condition of COVID. This is steroid. Okay, well, with steroid we win. So this patient, joint pain improved. Like first shot of steroid given, methylprednisolone pulse therapy was tried. The next day he's better. He's sitting on bed and talking to his relatives, has a smile on his face. It's like we win. So steroid helped us. It rescued us. That's what we thought at least. Well, it didn't stay the same because on that day of when we were seeing the patient on that day, we noticed something unusual. There was a surprise waiting for us. Though the patient had recovered from the complaints that he presented to us with, he had the following things on that day. Remember, we couldn't evaluate him in detail, especially the nervous system part. But on that day, something unusual was noticed, and we did a detailed examination. He had distal weakness and exaggerated reflexes in the lower limbs, knee and ankle. Okay, and the weakness was limited to the ankle, where he couldn't dorsiflex and plantar flex, move the ankle joint powerfully. There was bilateral extensor plantar response and ankle fullness, a very strong sign of involvement of upper motor neuron. Upper motor neuron would be either the neurons that are limited to brain or the spinal cord, right? And so this strong suspicion of nervous system being involved in this patient, and we were not prepared for this. We were treating the patient with fever and polyarthralgia, correct? So now this was a surprise. Well, we had a facility to be in contact with a neurologist, so we dialed him up, asked him to have a look. So on his after his examination, the opinion was that this could be possible post-infectious myelitis. Okay, and the advice was to get the cerebrospinal fluid analysis and also the imaging, hair imaging, magnetic resonance imaging, and both were normal. I know there are some findings that I have written here. You can take a screenshot for this. You can know the normal limits of protein, sugar, and cells. No? So you want to use this screenshot, you can take that. But otherwise, it was essentially normal. And sugar, except for sugar, which I have highlighted in bold red, but that is just marginal. So this was not something which was significantly contributing to diagnosis. So basically, after the neurology opinion, the evidence, we didn't get much of the evidence. Okay, and meanwhile, as a physician, we continued putting effort to find what could be on the other side. Because see, till patient recovers, it is okay to have him. But once the patient is healthy and the complaint he came for is disappeared, it becomes really trouble to follow up because they want to go home and get on with their lives. So we tried our best to move the results as soon as possible, and this is something which we got. Mind you, the ANA was is a screening procedure, right? It is the one which tells you whether to go ahead for the next, which is the costlier test, as a guideline. But still, because we were not satisfied with the improvement and we still had some suspicions, we went ahead with the ANA 15 screen, though the titer was not significant. And to our surprise, we found them to be significant. Patient had anti-Smith antigen positive, which is highly specific. Some literature mention that anti-Smith is highly specific for systemic lupus erythematosus in close to 95 to 100% of the patients. Like for example, if this is positive, then the patient out of 100, 95 or 100 out of 100 will have systemic lupus erythematosus. That's how specific it has been mentioned in literature. Anti-SSB and anti-PCNA also are little specific, but to a lower percentage. Anti-SSB is a little higher. And also they point to another autoimmune condition, which is Sjogren. But we still, in the amount of evidence we had amongst this, we picked this one and tried to move with that could be one possible diagnosis. Well, but the patient didn't want to stay with us more. So the thing he came for was done. So he didn't want to spend more time with us, though it was of our academic interest. Then at the time of discharge, we can't discharge patients without knowing what is the at discharge status, right? So that time when we investigated, we had some good improvement with the total leukocyte count that had come down. ESR was decreased better than before, so we were expecting improvement in that also. CRP was very but fully not normal, but it was showing a dramatic decrease. Anti-streptolysin O was also showing a decreasing trend. So what this means is the ASO titers peak 3 to 4 weeks after the infections, the recent streptococcal infection. So that means the peak infection must have happened. If this is the peak, then it must have happened 3 to 4 weeks prior, right? And then urine examination was done, which was normal. I think this is just a spillover of the follow-up investigation. Okay, so now the patient is to be discharged. Now I have to like there's a documentation to be done. I have to communicate to other doctor whom he will visit, like what happened to him, and there were a lot of questions. And wisdom is something which you gain with experience. Um, Seeing this patient, this was the first patient in whom I saw these things. So my experience in this was very limited. So I don't have enough wisdom to handle this case. I don't think many would be. This is not a common case which occurs like with fever, polyarthralgia, and sometimes you suddenly you see a nervous system involvement. So even the wisdom in the people whom I was in touch with, that would not be sufficient to say like, okay, I have seen this case, hundreds of cases. So when you don't have enough wisdom, what you're going to do? You're going to look for evidences. That's why it's recommended that to follow evidence-based medicine, because experience-based medicine, very many new things happen. Look currently what's happening, right? So evidence-based medicine. Okay, and here is where I'm introducing you the concept of black box. Okay, so let's look for this is a see black box is not an answer. This is a way to question yourself. This is a question to you. Okay, let me explain the analogy. This is a black box, which actually is not black. The name is black, which is used in flight, because when the flight meets with an accident, then you need to gather enough evidence to see like what happened. Okay, it's not to find answers like why crash happened. Oh, I'm happy that this now I got to know why crash happened. No, after the crash happened, the details that you gather is a question: how are you going to prevent this in future? How are you going to see that there is no more crash happening? Like what happened to this flight never happens again. So it's a structure to question yourself. Similarly, there's a concept of black box, which is slightly differently applied to our medicine. You can use this way. The input, you know what is the input, you know what is the output, but you don't know what's happening inside the black box. For example, television or a fridge or a washing machine, like you have to switch on to make the motor on. Then outcome is fridge will keep the things cooler, washing machine will wash clothes, television will project screen, right? They will show pictures on the screen. You know the output, but only the expert knows what's happening inside the black box, right? Same way, in our practice, we know there are conditions which causes input, the inflammation, and output, which is immunosuppression, which work wonder for many diseases, including this patient. We gave steroid and he was responding very well. But it will not only thing that differentiate us from the quack who will give steroid to just improve pain is knowing this detail. So what's happening inside the black box, which we are in that profession, right, to elicit some ideas what's going to happen inside this, what may be happening, so that you can make a difference. Okay, so let's use the evidence to decode these boxes, and this is where it gets really dense. So I want you to really focus, be attentive for the next few minutes, and take screenshots whenever, because I'm not going to be reading for the whole duration. So there may be some places where There are details are dense. So what will help is a screenshot, and I will be highlighting what was important and relevant to this case. Okay, the first evidence that says is this condition is reactive arthritis. And the picture you see is keratoderma blennergicum, a characteristic cutaneous manifestation associated with reactive arthritis. But well, this is not the picture of the patient. Okay, patient did not have this. Okay, patient had something else, some other evidences which said it's reactive arthritis. So let's see what he had. Before that, let's understand the basic pathology, what happens in reactive arthritis. So basically, there's an infection with a agent, bacterial or viral, which invades tissue and survives intracellularly. Most people think reactive arthritis means infection happened, must have happened in recent past, and then body sets in when there is no infection. No, reactive arthritis, the established mechanism now is the infection is still persistent, but the only difference is it is not causing a pus-like formation or a direct survival inside the joint space, but it can be in the joint lining, the ligaments and things like that, where they have extracted these pathogens. Okay, so they survive and intracellularly, and then they activate immune system, and then the damage happens. Okay, this is different from other reactive conditions that people know, like some old infection that's body getting reactivated. This is different in reactive arthritis. Okay, and see, this is a line-to-line thing from a standard book, and the red things are the things which our patient had. So what will help is you taking a screenshot of this. This is like completes the whole chapter of reactive arthritis in short 10 points. Okay, but I'm going to highlight what was there for our patient. Our patient had a gram-negative bacterial infection, E. coli. Commonly, the Campylobacter jejuni, Campylobacter, the chlamydia, mycoplasma, these are things that can cause Shigella, Salmonella, things like that. E. coli causing it is little rare, but that is possible. And we had a blood culture which was suggestive of E. coli. The age range was fitting. Our patient was 20 to 23-year-old, so it fits into this age group. The history wise, he has acute arthritis, which was asymmetric. It was adding on over a period of 1 month. And it was incident. He had an antecedent infection within 4 weeks. It could be ASO, even streptococcal causes arthritis, but when we are sticking to reactive arthritis, E. coli is the most stronger agent you would like to consider than the streptococcus, and he has that infection chance because we have a blood culture positive. And the rare manifestation of reactive arthritis could be myelitis, which we think we had seen, the nervous system manifestation of distal limb weakness of upper motor UMN type of weakness with clinical signs like clonus and bilateral plantar response, extensor response. Patient responded to steroids, not much to NSAIDs. That was there. We were using antibiotics, though their role has not been specified in acute arthritis. It's controversial whether they benefit or not. We were using it, provided patient also had infection. So this justified use of antibiotics. So this evidence was telling us this patient could have reactive arthritis. Okay. Now, when you search a little bit deeper, one thing funny about all these diagnoses that we're going to make now is everything says this is the possible diagnosis, but after excluding other diagnoses. Okay. So you can say it is reactive arthritis after excluding other causes. So you have to consider other causes. So when you consider systemic lupus erythematosus condition can be diagnosed after listening, like avoiding other causes, other infections. So it's like little funny. You need to juggle between the diagnosis. This picture shows a malar rash, a characteristic of systemic lupus erythematosus. Well, our patient did not have this. He had something else. Again, I'm going to point the evidence to you. Again, the basic pathology, either due to genetics or the environment he lives in, there is an abnormal immune response in the body and starts damaging his own tissue. That's the basic mechanism for systemic lupus erythematosus. Again, quote unquote, same things from the book. So let's see what was fitting. This was a criteria which is now outdated. We have a fresh criteria, but when the patient presented to us, this was the criteria we used to diagnose him. Again, please take a screenshot. I'm going to go only through the red ones. So ANA negative lupus exists, and prevalence has been told to be close to 2%. Like out of 100 SLE patients, you will not have ANA to be positive in 2 patients. That's what it means, right? And they may have other antibodies that are positive, like anti-Rho, anti-DNA. Well, Rho and La are slightly related antigens, antibodies. As I put the word on Sjogren. Antibodies to Smith antigen is very specific. I also mentioned the specificity, right? That was positive. Anti-PCNA could be 5 to 10% chance of SLE. So that was a strong evidence we had. And they also respond to steroids, which we use in this patient. Now, this was the old criteria. which said one in this, and should be more than four. So what the highlighted were all positive. You may This may catch your attention. There was thrombostopenia of less than 1 lakh, which initially our patient did not have. But when we maintain follow up with the patient, after 3 months, when he presented to us back, like that time he had a platelet which is thrombostopenia. One thing that about the this criteria of SLE is they need not happen at the same time. They can happen on any occasions. Only thing is those criteria things have to match. No, but at that time when in the follow up, one good thing was his auto-inflammatory activity. If it was there, that was under control. His ASO returns were decreasing the decreasing time, and also urine was positive. Urine protein was positive in the follow up. This was not a good thing. I will tell you. For a diagnosis, it is good, but for a patient, it may not be a good thing. Well, the criterion has changed for SLE, which is recently by 2019. This is the criteria we use, where the entry criterion has to be like ANA has to be positive, otherwise don't. No, just and see one about the guideline is previously we know that ANA negative lupus exists, but now the entry criteria is ANA plus. The guideline is to minimize the cost burden and things like that. So if you don't suspect everyone as SLE and keep sending whether it is negative or not. Okay, so that's why the guidelines are there. They don't say like the other things cannot happen. They just guide you. Um, like when you consider that our patient had ANA positive 1 plus, which says that you can take him into the entry criterion. And then the additional criteria were there, right? The additive criteria, well, there is a next slide which will show the list. If you want to take a picture, start taking a picture now. The next slide which shows the patient should have more than 10 points. The criteria are there in the next slide. So this is the criteria you consider, and this is the weight you give. The score has to be more than 10. So let's see what happens with our patient. Fever is there, score 2. Then you come down, there is thrombocytopenia, score 4. So 6 here. And then there is, sorry for that. There is joint involvement, 6 again. So score is 12. Already we crossed 10. But this has to be like also has to include something from here also. That's the basic requirement. So when you come here, we have anti-Smith antibody or anti-DNA antibody. This was negative. Anti-Smith was positive. So this adds 6. It's like we got 18 score out of this in the new criteria also. And mind you, we have not done these reports, low, like to get the C3 level, C4 level, this lupus anticoagulant, this group, or patient had protein, but we did not want to risk following up too much on this patient who had just presented to us for a follow-up. And this was not done. Had we do this, and if anything adds, the score will be even higher than 18. Okay, so this gives a strong basis to consider systemic lupus erythematosus as a diagnosis in our patient. Well, this was a chart again from a standard book, which just shows that even if it is ANA negative, sometimes patient will need treatment of SLE. That's what I wanted to highlight in this slide. Well, next moving on to the next thing, the evidence says the patient has rheumatic fever. Well, this is a picture of Sydenham chorea. Our patient did not have Sydenham chorea, but he had something else. So this is the criteria on which we diagnose rheumatic fever. Okay, two major and one minor, two minor. But for our patient, relevant detail was this. Okay, I'm going to read the detailed ones from only till here. Patient may present with polyarthritis or with only polyarthralgia, which our patient presented with, or monoarthritis. I have not changed any sentence here. This is just the same sentence as you will find in any standard book. Okay, and other minor manifestations, which I'm going to show it in next slide. What was positive and negative for him, and a recent streptococcal infection. That evidence was there for us. Then you should consider it as probable rheumatic fever, not confirmatory one. Again, it says include other causes, try to find other causes. If not, then consider possible rheumatic fever. Okay, so when we came to this criteria, we found the minor criteria were satisfied. There was fever, elevated ESR and leukocyte count, and recent streptococcal infection. These things were satisfied. The major manifestations was, as I said, there could be simple polyarthralgia. Otherwise, this was not there. Though patient had a short systolic murmur, which on echocardiography also proved to be present, there was no signs of rheumatic heart disease. Okay, so I would not say that major criteria was satisfied. One criteria was polyarthralgia, not arthritis that we had. And the echo also showed the persistent of moderate MR, just making sure it is not a acute MR. Acute MR in rheumatic fever may disappear with improvement, but this was stayed. Okay, so the more possible explanation could be this. This again is one of the standard books which says that patient can occasionally be found to have moderate to severe mitral regurgitation with no evidence of heart failure, no evidence of dyspnea, and they are mostly incidental. Okay, and you don't have to have a strong basis to include this into the criteria. Now this is what this evidence is. It's just incidental one, and I'm aligned with this. I wouldn't consider it to be a strong evidence for rheumatic fever, but at least the evidence says when you consider in the first incidence it could be a rheumatic fever. Again, the idea is not to get one diagnosis. The idea is to make a difference to the patient when you're considering what is happening inside the black box. Okay, and the next diagnosis that the evidence says is this could be multiple sclerosis. Oh, it's a little surprising, but um, see, if I told you something about the past history, patient says he had similar complaints 4 to 5 years back, and I said it's a little doubtful. But what if it was very significant? What if patient had fever and joint pain, he was treated well with some steroid and he got better, and he has come to a second time? And when we are finding there is sign of nervous system involvement, just consider like similar conditions happening. One condition that can happen with such demyelination is multiple sclerosis. Okay, and if I have to fit into this, I would fit him in relapsing remitting criteria type. These are the types of multiple sclerosis where I would try to fit him in relapsing remitting if that history was sure was true, the past history. Or otherwise I can make this diagnosis only in the background, watching for the follow-up. And in this only time can answer, like when the patient presents to us 5 years 6 years later, one complaint of myelitis, then he fits into this criteria, right? So our patient, well, we don't have a strong evidence for this, but let's see what this has to say. Um, well, the thing we elicited was plantar reflex, right? This says this again is quote unquote from a standard book. What exactly it says I have put here. This says an expert neurologist can make the plantar go up, extensor, flexor, anything, depending on his expertise. Okay, but when your intention is genuine, try to elicit. We really found plantar reflex was there, but still this is a weaker one given the technique and all those things. Consider that I did a mistake. I did not elicit it properly, and there was a mistake. Consider, but everything can't be the same, right? Clonus was there, and because MRI was normal, the CSF analysis fluid was normal, so it was not showing any inflammatory activity. The only evidence I have with me to tell you that there was nervous system involvement was clinical findings. Okay, and if you are doubting the clinical condition, then there were so many things which were adding up. For him not able to lift his leg, this is not a clinical sign; it's an observation, right? Um, so plantar reflex may be doubtful, but not the clonus or the weakness. So it's a strong point to consider that there was nervous system involvement. And also we had a neurologist with us who was supportive of the clinical finding and who had ordered investigations to find out what was happening, right? And again, the red things in multiple sclerosis, the first presentation could be myelitis, simple myelitis, isolated myelitis with incomplete cord syndrome. So if you're thinking, oh, bowel and bladder was not involved in this patient, it is possible to have spinal involvement without bowel and bladder dysfunction also. Okay, that will be fitting into some incomplete cord syndromes. Okay, so there's 11% chance of they being diagnosed with multiple sclerosis in future. So this patient carries a risk of 11%. And the other thing, how can the MRI be normal? Like the diagnosis of multiple sclerosis depends on two things. There has to be dissemination in time. The findings have to be at least 1 month apart, and dissemination in space. That means the nervous system involvement has to be in multiple places. Like a brain one time, spinal cord one time. In brain also there are multiple periventricular areas or the cortical areas. Like you can find multiple areas and try to fit in different areas, different neurological findings. Um, so those findings were not in this patient. We had a normal imaging. So this is what it says: up to 40% of transverse myelitis cases, like where the complete cord involvement is there in inflammation, may have a normal finding on MRI. So when our patient has a mild myelitis, it is possible that imaging might not be fully supported. Okay, and this when I came across this was as if it was written to our patient, where neuroradiological investigation and spinal fluid analysis exclude a structural abnormality. Like MRI didn't show any structural abnormality, which was very supportive of compressive myelopathy or things like that. Okay, but also failed to provide evidence sufficient for diagnosis of multiple sclerosis. Remember, there is no inflammatory activity, nothing was there. The wise clinician will repeat all the investigations after an interval. Now, this is the interval that we need to wait for, and then again repeat someday when he presents with some other complaint, or maybe just if for follow up, if without any complaints also. But that is a thing that we need to wait. And this is one interesting term which you may be like, which may be fascinating to know. In the diagnosis we considered, there was systemic lupus erythematosus and also multiple sclerosis. Well, there are conditions where there is a collapse between these two, where the disease tends to be like lupus sclerosis, but then slowly transforms into multiple sclerosis. One important thing about this is there is these patients have antiphospholipid antibody also as positive. In the antibodies that you consider, these patients have strong predilection to have antiphospholipid antibody syndrome, shortly known as APLA. Excuse me. Okay, and so this patient, we did not get it done. That test was not done. It was difficult holding the patient, and we were trying to support him in as much as possible. We couldn't continue supporting him for everything, so this was not done. But it's an interesting thing to enrich our knowledge to know like this condition also could be a possible diagnosis. Okay, so let's look at our peculiar things in our case. So this patient evidence says it could be reactive arthritis, but the organism E. coli is rare, and myelitis also is a rare presentation. But fever with polyarthralgia is absolutely justified with this reactive arthritis. Next, systemic lupus erythematosus, we had ANA negative, anti-DSDA negative. Well, this was positive, but it was insignificant. But we had a strong one who is supporting was anti-Smith, and myelitis is reported. Antiphospholipid antibody, we didn't do it, and it almost satisfied the diagnostic criteria that was there, the old one. But thrombocytopenia developed, so it satisfied the criteria later. Then the rheumatic fever, it fit into possible rheumatic fever. In the multiple sclerosis, it could be a first presentation where it is radiologically normal imaging is possible. So this was the diagnosis, and this was the peculiarity. And lupus sclerosis is a controversial one. We can't just merge when both are doubtful. We'll have to wait and watch before we label this patient as lupus sclerosis condition. Well, you may ask, like, why is it important? We have given a steroid, patient is better. Next time you come, he gives steroids. No, it's not that simple. Each diagnosis has a different regimen. It's lucky that he responded. I hope he responds that way every time, right? But in future, if something happens, we need to be ready. And this time, after all the work we have done, now we are ready to face what may happen. And for you to distinguish why it is important, um, see, reactive arthritis has a treatment of this one. Please take a screenshot of it. I will. This will be again. Otherwise, it will be boring reading of this. Take a screenshot of this. The point I want to make is every treatment that we consider has a different treatment regimen that needs to be followed. I'm reading this line just to find out the APLA syndrome, which we didn't do. The striking response to anticoagulant therapy. That means the patient really responds well to anticoagulant therapy, not the steroids in this condition. Okay. In some patients with MS and APLA positive, is probably the strongest argument for distinguishing the diagnosis. So this says only for antiphospholipid antibody. We just missed one, and it supports that. You need to distinguish that also. That's what it's telling us. I just want you to expand this description, this evidence to the whole of the thing. It is the same for the rest of the things also. You need to, whatever the treatment regimen is opposite to it, they are responsive to that. Okay, so you can't replace one regimen to the other one and try and fix every time. So that's one of the strong reason why you need to distinguish a simple fever with polyarthralgia and some peculiarities. The limitations are, first thing is HLA-B27. Most people will go for that investigation first. The limitation itself is of interpretation. Most people who have HLA-B27 positive, but still have no complaints. It's like in general population also they are positive. So it was not going to add anything more beyond what we already knew. So we didn't go for that. But some people may find that that test was missed. Antiphospholipid antibody that was supposed to be done, we couldn't, but we now have the knowledge to get it done next time. Anti-myelin antibodies, well, little costly, and we are not going to pushing for that. CSF oligoclonal bands could be considered in future again if he presents just like APLA. And the last limitation, the follow-up. Now this patient was there with me. Someday he may come to you, or he may come to a place where I am not available. Right? I might have shifted somewhere, and he comes here. The knowledge that I have shared, if that is not given to you, and you are not in a condition to utilize all this information, patient may be lost to follow-up, and in follow-up he may miss. This condition may be missed. So that is one limitation we have with this patient. So take-home message. Uh, well, the APLA, we missed the APLA sending antiphospholipid antibody. That is the take-home message for us. And a trial of oral anticoagulation could have been tried to see if any neurological improvement would have accelerated further. Well, during follow-up, I was happy to get to know that his power had improved. But again, whether the anticoagulation could have made a difference, I'm not aware. So, but now have the adequate knowledge to have this for future thing. The last bullet. This is the take home message for any student. Guidelines too may not be able to guide, and practicing medicine is a humbling experience. Not truly is. In this patient, I don't. If you ask me what is the diagnosis, I'll be probably telling you I don't have one. But for the sake of communication, I would put my first diagnosis of reactive arthritis, strong possibility of systemic lupus erythematosus being in the background, to letting know the doctor that this could be that also. But I have to have one diagnosis now for the sake of communication. For that, I may use reactive arthritis. I hope it is. It's also my desire that it stays as reactive arthritis because it's one which will not have long-term complication. I pray that the patient has this only. Out of all the things considered, I'll be very, very satisfied if my diagnosis of reactive arthritis could be the strong one. Well, these are the references. You can use it for this presentation, or you can use these books. Very good presentation and all these things. Can use that. Well, my thank you message to you. Being humble means recognizing that we are not on earth to see how important we can become, but to see how much difference we can make in the lives of others. So our treatment goal here, our interviewing goal here, our time that we spent with the patient, the money we made him to spend, the money we spent on him, all those things were not to get the diagnosis, but to make the difference to him. So we are happy to say that we don't have a diagnosis, but the patient difference has been made, and we are ready to make a difference in case something happens to him in future. Okay, and thank you for staying here. I know there was an interruption in between. I'm really grateful for those of you who stayed here during that time, and I'm blessed to really interact with you. I'm going to stop the presentation. If there are any questions, I will take them now. Um, okay, so um, I'm going to spend 30 seconds to communicate something else. Meanwhile, if you have a question, you can type. I've told you there's a lag of 30 seconds. So if you have a question, please type it as soon as possible now. So next 1 week, there is some exciting thing I want to tell you. First thing is, if you notice my short haircut, it is for I'm going to go for a currently to treat COVID patients. I want your blessings and wishes to manage this successfully and be there. After that, during this period, I'm not going to be away from you. I'm going to still continue to see like how I can continue interacting with you. And an exciting opportunity is that I'm going to release a new video, which was initially for the other channel, which has a which are very short, like 5 minutes, 3 minutes, like that. But in the end, they have a slide which gives a condensed information again, like the one that you had today. Okay, so when you are going through those slides, um, going through those videos, you can take a screenshot of the last slide, just like the one we had now. That will make a real difference for you when you are trying to recall things, either to write in exams or to benefit the patients. Okay, so in that note, I don't see any questions there. So thank you for giving me this opportunity to be with you. Okay, take care. See you very soon. Bye.